This is CCTA case number 37. It's a 75-year-old man with known coronary disease who is status post-coronary artery bypass surgery with 4 conduits, as well as multiple stents for narrowing of these bypass grafts. He now has atypical chest pain, and we are asked to evaluate whether or not the stents are open and what is the status of the bypass grafts. Evaluation of coronary bypass grafts can be quite challenging, but it's relatively straightforward if you use a systematic approach. We can see here that this is a full view of the three-dimensional structure. I will frequently switch to a right view as I'm going to rotate around here. I need to first of all look at the status of the sternum. The sternum, of course, is intact, and I can see that there is a very large right internal mammary artery that is situated on the chest wall, but the left internal mammary artery, which should be approximately in this position as shown by the arrow, is absent. So I know that they've done a Lima graft at least. The best situation is to first of all do some sculpting, which I'm going to do now by rotating down a portion of the area and then trying to sculpt out some areas. I'm going to first of all go to the sculpting tools and do include region plus region, and then try to cut out as much as I can of the areas that will not be cardiac surfaces. I apply that, and I can begin to get a little better idea of the bypass grafts here. I need to do a little bit more sculpting involving the sternum here. I'm going to do a minus region sculpting here and trace out this region and then apply that. So as I rotate around here, I can see that there are a number of bypass grafts. I need to do a little bit more sculpting here of a particular area, that negative region, and work on some other areas of the pulmonary vessels that get in the way of looking at the three-dimensional aspects. Apply this. Now I have clearly 4 bypass grafts that are identified. There's a bypass graft here to the right coronary. I can see a stent clearly in that distribution. I can see a left internal mammary artery that's coming down probably to the left anterior distribution. I can see a bypass graft that appears to be coming probably to a region of a first diagonal. And finally, a saphenous vein bypass graft that appears to be coming to the obtuse marginal region. So right off the bat, I know that the 4 bypass grafts are patent. In order to look at them in more detail, though, I need to go back to the two-dimensional views, and I'm going to bring over the maximum intensity projection 5 mm and begin looking at the bypass grafts. Let's first of all start with the internal mammary. There is the left internal mammary artery. I know that it goes to the anterior wall, so I'm going to actually rotate in that direction, and I can see that the Lima is coming down very nicely, clearly going into the region of the left anterior descending. I have 2 phases here, so I'm going to just switch to the other phase for just a second. It doesn't really help very much, but I can see that this graft is patent, and then as I go to the LAD, I can see that it has good flow down into the apical region. I'm going to switch next to the foot view and start taking a look at the other bypass grafts. So I've looked at the Lima. I have another bypass graft coming off approximately here. I can look at this as it comes off the aorta, and I can follow it down. I'm going to down and navigate down about 45 degrees. And I can see that this graft is also coming over to a region with very good flow. If I'm not quite sure where that is, I'll hit the foot view again, and I can see, ah yes, that is a first diagonal branch with excellent flow. So let's switch back to the foot view and go back up, identify the third bypass graft. This one has clearly a stent in place. Bring this into the center. This graft is clearly widely patent. It has very good flow down to an obtuse marginal. If I want to look at the graph itself, sometimes that's a bit more of a challenge. I'm going to switch to a foot view here. These are a little bit bright. You can change the window and level a little bit to try to reduce some of the glare. But importantly, you need to switch from this 5mm MIP to an MPR view. Once I get into the MPR view, I can see that this stent is really quite widely patent. So I have a patent stent with good blood flow into the OM bypass graph area. I'm going to go back to a 5mm MIP and look at the last bypass graph. Here's the right coronary graph coming out right about here. I'm going to rotate around just as if I would using a looking at the right coronary. This a little bit better here. We can see this is widely patent. There is a graph here, and I can put that in the center, switch to an MPR view, and try to look at that graph. Again, appears to be widely patent. I really don't think there's any issues with respect to a compromise of flow into that stent. I'm going to switch back to a 5mm MIP and proceed all the way down. I can follow this graph all the way down. There's another stent here in the inferior distribution of this graph. I'm going to switch to a foot view, and I can see there is good flow now down into the PVA. If I wish to look at this graph, this stent, it's a little bit smaller. I'm going to switch to an MPR view. It's a bit more difficult to evaluate, but this is clearly widely patent. Probably having done a harder kernel than this type of reconstruction probably would have helped, but I believe that that graph is perfectly acceptable. We want to turn briefly to the native coronary arteries. These are usually rather difficult to evaluate properly because they're usually so severely diseased in the area of the bypass graph. You can see that the LAD here is essentially occluded. I've got a internal left circumflex vessel here, which is also quite small and probably has got severe disease. I've got a native right coronary coming off here, and this likewise is essentially occluded in the proximal segments. Now you'll notice here as you start looking at that, there's a little bit of a collar around the aorta here. Now I don't have any more history in this patient. Frequently you are compromised with respect to total history on these patients, especially the bypass graft patients, if you don't have any operative history. But this is evidence of a prior dissection in this area. You can get a little better look in a longitudinal view, if you will. You can see again this collar around here. Again, I don't know anything about this patient's surgical history, but I would say that there probably also might have been an isolated dissection. So we have in this gentleman, we have 4 widely patent bypass grafts with multiple stents in place, which are also without narrowing and functioning properly. There's an occluded LAD, an occluded right coronary, and a severely diseased left circumflex, and an area that suggests that there had been a prior type A ascending aorta dissection. But again, we need better history on this patient. So in terms of disposition, frankly, nothing else needs to be done. We've identified the grafts and indicated that this patient should not be having any ischemia from results of his surgery.